क्या हुआ? Good evening, all.
Good evening,
sir.
Today, who is answering?
Sir, I am answering, sir. Dr. Abhishek from Jaslok Hospital.
Sir, I am Dr. Amit Bulra from Jaslok Hospital.
Good evening, sir. Sir, I am Dr. Tushar Karmate from Dhule, sir. I am answering today.
Okay, so 3 people are answering: Abhishek, Amit, and Kishore.
Yes, sir.
Tushar, sir.
Yes, sir.
Yes.
Good evening, Pankaj sir.
Good evening, bhai. Just getting ready for the session.
Yes. सर को थोड़ा शायद टाइम है ऐसा लगता है.
किसको?
गौरंग शाह
सर को. ओके.
आज का जो भी टारगेट था पूरा किया मैंने.
गुड.
चल रहा है, देखते क्या होता है. So we both will start if after 5-10 minutes.
Sure.
Okay, sir.
But I think I saw him sometime back.
किसको?
अपने गौरंग शाह सर को.
He is joining, but probably busy in some work. That's like.
Okay.
So Paras 24 now.
Hello.
So when is the expected date of exam? Abhishek?
Sir, most probably, sir, August end results are expected, and sometime in first or second week of September, practical exam is expected, sir.
Okay. So who is presenting the case? Paras, na?
Yes, sir. I will be presenting. Hello.
We will wait 2-3 minutes and start.
Yes.
It is near about 30 people already joined. So should we start? Paras. Hello.
Hello. Yes, sir.
Paras, are you ready?
Yeah, sir.
So should we start?
Yes, sir.
Okay, go ahead.
So the first case is to Dr. Tushar.
Yes, sir.
Presenting case history of a 36-year-old gentleman resident of Jodhpur, Rajasthan, presented with the chief complaint of blood in urine since 1 month.
Okay. Sir, with this presenting complaint, I would like to know the nature of the this complaint and characteristics and duration and progression of the complaints. Hello,
29.
hello.
Okay, go ahead.
Yes, sir. Yes, I would like to also know whether this symptom is associated with any other lower urinary tract symptoms or any pain in abdomen, or whether it is associated with any blood clots.
So in short, this is the only cheap complaint, and you have
Yes,
to
sir.
elaborate this cheap complaint in terms of blood. So is it continuous? Is it intermittent? Is it
Yes, sir.
associated with pain? Is it associated with clots? What are the types
Yes, sir.
of clots?
Yes, sir.
Then is there any history of lower urinary tract symptoms? Is there any history of associated any history of acute urinary retention? Any history of
Yes, sir.
passing the stones? So in one go, if there is a blood in the urine and the patient is 36-year-old male, so what
Yes,
is
sir.
the probable expected pathology in the young male patient presenting with blood in the urine?
Sir, as per the age of patient, most probably it may be associated with the urinary tract infection. And second cause will be the stone disease, vesical calculus that might be present with blood in the urine, or any upper ureteric tract stone, or any renal calculus that is presented with such complaints.
So whatever history you have asked for us, please provide the history.
Yeah.
Yes, sir.
History of present illness. History was given by patient himself and seemed to be reliable. According to patient, he was apparently asymptomatic 1 month back when he started having blood in urine, sudden in onset, progressive, complete, associated with passage of clots, and was also associated with pain in flank. There are also episodes of painless complete hematuria in between. The clot were of amorphous shape. Patient also had similar episode 1 year back, which was relieved by medications.
Okay.
So this is the history.
Yes, sir. Sir,
So
as yes, sir.
have you changed your diagnosis, infection and stone, or any other diagnosis you are entertaining now after
Yes,
listening this?
yes, sir. I would like to keep another diagnosis as a any benign renal tumor that is associated with the flank pain and intermittent episodes of hematuria. Because
Benign renal tumor.
yes, sir.
Which benign renal tumor will cause hematuria of this strength?
Sir, maybe a renal cystic disease that is associated with the intermittent hematuria.
And how did you conclude benign?
Sir, as per age of patient and since 1 year, so most probably it may be associated with the benign conditions of kidney that is giving rise to the only hematuria and flank pains.
A 36-year-old male
Yes, sir.
presenting with intermittent hematuria. In
Yes,
between, it is a painless and
Yes.
with pain.
yes, sir.
So you are expecting a blood tumor, renal tumor, and that is again of benign nature.
Yes,
So it is very, very rare, I feel. So the classical triad of RCC or
Yes.
malignancy in very delayed phase, nowadays it is only in 10 to 20% of the people, and majority patients, it is detected incidentally.
Yes, sir.
So commonly still what I feel in exam after listening this history also, your first diagnosis will be stone only.
Yes, sir. Stone disease first time.
So because it's that pain and hematuria both can be explained with the stone.
Yes, sir.
Sir, one small
Then
suggestion
another
that
thing is bleeding. Yes, sir.
नहीं आप
Yes,
complete करें.
Then another things in such type of patient is AV malformations.
Yes, sir.
Vascular malformations are there at this age, and such type of malformations may bleed intermittently, and due
Yes.
to the clot in the ureter, he may have pain. That is another
Yes.
cause.
Yes, sir.
Sir, boliye sir.
And my suggestion will be don't make such precise diagnosis of benign tumor. Okay.
Yes.
Yes, sir.
The moment you make such diagnosis, the examiner knows that you know the case.
Yes, sir.
Okay.
Exactly.
Nobody, like in my OPD, I have never diagnosed any patient with benign tumor.
Yes.
So
I think we should not diagnose pathology, correct?
Yes, sir. Yes,
precisely,
sir.
precisely.
Yes.
Okay, Paras, go ahead.
One more thing I want to know. Okay, looking at the shape of the clot, what the place of origin, can you think of?
Uh,
Whether it is from ureter, whether it is from the kidney, whether it is from the bladder.
yes, sir.
Just see all the shapes. See one
Yes,
on
sir.
the right. I'm not in the exam point of view, but just look
Yes.
at them. What do you think they are coming from?
Sir, they are mostly globular, so might be coming from the bladders.
Just see properly.
Yes.
Just analyze them,
Yes.
Opposite side. First slide. See the shape of the clots.
Yes, sir.
Yeah, they are very, very small clots. They are
Yes,
very
sir.
small clots.
Very small. Yes, sir.
I'm just for the academic point of view. They are like from the small cavities or from the like a calyx. Or
Yes,
they
sir.
are from the small cavities,
So theoretical point of view, if the clots are serpentine and longitudinal, they are coming from the upper tract.
Yes,
If
sir.
the clots are amorphous, globular, they are coming from the lower tract. That is bladder.
Hold up. Yes, sir. Yes.
This is theory.
Yes, sir. Sir,
Okay, Paras.
Yes. Negative history. There is no history of fever or burning maturation. There is no history of lower urinary tract symptoms.
So
No.
no any significant negative history.
Yes.
yes, sir. Yes, sir.
So how will you go ahead?
Sir, I would like to know any other comorbidities associated with this patient. I would like to know about any past history of any surgical intervention, any medical comorbidity, and I would also like to know any family history of similar episodes in his families.
Okay.
Past history and comorbidities. Patient is a known case of hypertension and is on medication. No history of diabetes mellitus, ischemic heart disease, thyroid disorder, or bronchial asthma. No history of any surgical intervention in past. Personal history. Patient is vegetarian by diet. No allergy to any food or drug. Sleep is normal and undisturbed. Bladder, bowel are normal and adequate. No addiction to any form of tobacco or alcohol intake. Family history is nothing contributory.
Yes, sir.
Okay, so no any significant contributory points in the past history and personal history.
Yes, sir. Sir, as this
So what
patient,
next?
sir, as this patient is having hypertension as positive history, and at the age of 36, having hypertension. So I would like to give addition one more differential diagnosis in this case. It might be associated with the first will be associated with the renal calculus or ureteric calculus. Then it might be associated with the polycystic kidney disease that is associated with the hypertension and immaturity.
नहीं आवाज मुझे ही छोटा आ रहा है या सबको छोटा आ रहा है?
नहीं, आवाज क्लियर है डॉक्टर साहब.
Clear.
आवाज
It is clear.
थोड़ा तुम नजदीक पकड़ो, थोड़ा जोर से
Yes,
बात
sir.
करो.
Yes,
आवाज नहीं आ रहा है.
sir. Now I'm here. Yes, sir. Hello.
See, we can hear you,
Acha, yes, sir. Yes, sir.
but Dr. Gite is not able to talk little loudly so that he can hear you properly.
Yes, sir. Yes, sir. Yes, sir. Sir, as this patient is having is of age 36, and there is only a positive history of hypertension. So I would like to give one more additional differential diagnosis for this patient, sir. That is polycystic kidney disease, sir. Hello.
Yeah, Dr. Gite. Okay, so polycystic renal disease you want to give as a second diagnosis.
Yes, sir. Second diagnosis.
Okay, what else? So what are your differential diagnoses? Just enumerate important.
Yes, sir. First diagnosis is renal calculi disease, sir.
Okay.
Then, yes, sir. Then the second diagnosis is ureteric calculus. Then
Just say lithuria, na?
yes, sir.
Urolithiasis. Just say
Yes, sir.
urolithiasis.
Urolithiasis. Yes, sir.
Okay.
Then
Then
yes, and then second diagnosis is sir, polycystic kidney disease.
okay.
Then yes, sir. Then
Commonest age of presentation of the adult polycystic kidney disease is it 32?
no, sir. It is in the 4th to 5th decade, sir. Common presentation. But sir, it can be present.
Any history in the family to support your diagnosis?
No, sir. Family history is not contributory, but as a patient is having hypertension, so I was more suspecting about the polycystic kidney disease, sir, because it is associated with hypertension and hematuria, most likely.
Usually clinical presentations start after the 4th decade.
Yes, sir. 4th decade is a common presentation. Yes.
Yeah. Okay.
Fine. Okay. Fine. Sir, we have to finish 3 cases. So we will go more on investigation and management.
Yes. No, that's why I am pushing.
Yeah.
Yes, sir.
So,
Okay. So
what
next
next?
what you want?
Sir, I would like to examine the patient first. I would like to know the general examinations and
Okay.
What are the possible findings you are expecting in this patient? Just enumerate.
yes, sir. Sir, I would like to know any fullness or any palpable lump seen in the flank region, or if there is any renal angle tenderness, I would like to know.
Okay. What else?
Yes. Sir, then
Dekho,
So
your
anyway,
diagnosis is polycystic disease,
yes, sir.
stone disease, and infection. So
Infection. Yes, sir.
tenderness, fullness, lump in the loin, and bladder
Loin and-
fullness, bilateral palpable kidney.
Yes, sir.
इसके अलावा कुछ और मिलने वाला है?
No, sir. At this age.
Okay. Paras, go ahead.
There is no significant finding in general examination.
Okay.
On per abdominal examination, it's normal. No renal
everything is
external.
normal. Basically everything is normal. So now next what you want to do?
Sir, I would like to evaluate this patient further, as there is no significant positive examination findings. Sir, I would like to do the first urine routine, then CBC, creatine, BUL.
So
And-
what you are expecting in urine routine in this patient?
Sir,
Because patient had a hematuria, there
Yes,
is
sir.
plenty of RBC will be the finding in the
Yes, sir.
urine routine.
Yes, sir. I would like to know the sir if it is associated with any other proteinuria, then pus cells, or any bacteria present in the urine. That may give me the differential diagnosis for the cause for hematuria, sir. Then I would like
In
to.
spite of that, you must tell like I will be interested in morphology of the RBC,
Yes, sir. I would like to.
because
Yes, sir.
if there are dysmorphic RBC, it is going towards medical hematuria.
Yes, sir.
If there are normal sized or shaped RBCs, they are
Yes, sir.
going towards the surgical hematuria. Then
Yes, sir.
along with proteinuria, if associated with proteinuria, again it is going towards medical disease.
Medical
So
disease.
just finding and diagnosis.
Yes, sir.
You should tell like that.
Yes,
Okay,
sir.
what next?
Sir, I would like to know the CBC, creatine, BUL, And then I would like to do the plain X-ray QB and USG abdomen pelvis.
Okay. Paras, show him everything.
The urine routine microscopy, pH was 6.5, protein, sugar were absent, RBCs were 110 to 130 per high power field. The WBCs were 10 to 15 per high power field. Epithelial cells were absent. There was no growth seen in urine culture sensitivity. Urine cytology was negative for atypical cells.
Show him. Yeah.
In blood reports, hemoglobin was 13, creatinine is 1.03, INR is 1.01, rest others are within normal level.
Yes.
This is the ultrasound film.
So my question to you is, in a patient of hematuria, after having a normal creatinine, what will be the best investigation?
Sir, for the purpose of diagnosis in a case of hematuria, if creatinine is normal,
So we are investigating patient for diagnosis only.
yes, sir. Then we can, sir, contrast renal CT abdomen pelvis will be the best diagnosis sir, for evaluation.
Correct. So
Yes.
if any patient of hematuria with normal creatinine should be evaluated with contrast
Yes.
enhanced CT with CT IVP and if required vascular reconstruction
Yes,
as per the finding of CT scan.
Yes, sir.
Okay.
Yes, sir.
So doing ultrasound and X-ray QB, you can justify like I'm suspecting stone disease, so I want to able to confirm the stones
Yes.
by doing both the investigations, but you are wasting the time, investing the time as well as investing the money.
Yes,
So
sir.
if you find stone also, what is your next investigation is CT IVP.
Yes, sir. Yes, sir.
Okay. So
Yes.
as an extension of clinical examination, you can tell that ultrasound can be done.
Yes, sir.
But in such situation, for evaluation of hematuria, the next investigation after seeing the normal creatinine should be contrast enhanced CT scan. Pankaj sir,
Yes.
is it okay?
I also
Absolutely
believe
okay.
that, you know, when the hematuria is there, I think sonography only you can justify, as you said, like, you know, as an extension of the investigation. And only thing is post-void reticular urine if one wants to know. Otherwise, CECT is the most important thing.
Okay. So Paras, dikha do.
Yes. Ultrasound findings. Ultrasound. There is a 4.3 into 3.3 into 3.2 centimeter lesion in the left lower pole of the kidney. Prostate is 24.3 grams. There's no PVR. PVR is 40 cc, not significant. These are the CT films.
Sir, actually,
See it carefully.
yes, sir.
Paras रहने दो, यही रहने दो.
Sir, sir, this is CECT abdomen pelvis with CT IVU. First few films they are non-contrast CT showing lower pole, left right normal kidney with left kidney with lower pole mass that is well circumcised. And then sir, contrast films are showing normal concentration and excretion of contrast in both the kidneys. Right kidney is normal, left kidney is showing almost 3 into 3 centimeter mass sir, in lower pole that is well circumscribed and there is no heterogeneous areas in the mass. It is homogeneous mass, non-enhancing homogeneous mass.
Is there any enhancement? No enhancement?
No, sir. Enhancement is not seen in the film, sir.
So how you have compared?
Sir, surrounding renal parenchyma that is showing the enhancement after the contrast.
Compared to surrounding renal parenchyma, it is not that much densely enhancing, but you
Not
have to
the density.
compare the enhancement with the non-contrast CT scan.
Yes, sir. Non-contrast film CT is
Because
showing enhancement. Yes, sir.
so this may be partially enhancing mass. I don't know the report, but I feel it is enhancing mass.
Yes, sir.
Enhancement may be more than 20 or may not be 20, but it looks like enhancing.
Yes, sir.
Okay. So renal nephrometry score.
Right.
Sir,
Tell us the nephrometry.
Sir, sir, mass is looking less than 4 centimeter. Then
Just tell us what is R.
yes, sir. It is endophytic mass. Then it is a not involving the
R is a
Is it completely endophytic?
sir.
So it is medially placed,
sir.
but is
Yes,
it completely endophytic? It is hilar medially placed lower polar mass.
yes, sir. Sir, but
Reaching to hilum.
remove renal parenchyma is seen, sir, around the mass in second film. Last
So
two
what?
film, sir.
So patient had hematuria. What it suggests?
Sir, it is says that this mass is involving the pelvic system, or it is
Correct.
Yes.
yes,
So go ahead.
Correct. You are correct.
yes,
So
sir.
radius is how much?
Sir, it is looks like less than 4 centimeters, sir.
Okay, 4, less than 4. So
Yes,
what
sir.
is the score?
Sir, score, yes, sir. Score will be the, sir, between 6 to 9, sir.
No, radius is, you are saying
Uh,
less than 4. So what is the value?
Yes, sir. Less than 4 centimeter is 1, sir.
1. Then it is exophytic, endophytic.
Yes, sir. It is a endophytic, sir. So score will be 3, sir.
Okay.
Yes, sir.
Then the
Sir,
next.
yes, sir. Sir, it is near to the pelvic system.
Yeah. So it
Yes,
is
sir.
bleeding. It has to
Yes,
be
sir.
near.
Bleeding. Yes, sir. Involving the pelvic system. So it will be 3, sir.
3. Then near to the hilum.
Yes, sir.
Is it near to the hilum?
Nearness to the hilum.
Yes, sir. It is near to the, yes, sir, near to the hilum. Lower pole vessel is seen near to the mass, sir.
So what is the score?
So you are bolo.
6.
So it is 9 to 10. Correct?
9 to 10, sir. Yes, sir. 9 to 10, sir.
Fine. Well.
Yes.
Okay. So
Okay.
now in this is now go ahead. What do you want to do? He is giving the report. By Paras, just tell the impression.
Yeah. An impression at CT study reveals a well circumscribed cystic lesion arising from the lower polar region, about 3.8 into 3.2 centimeter in axial dimension and 3.5 centimeter in the craniocaudal extent. Following post-dynamic contrast study, this lesion is showing minimal enhancement of all its wall. A small focus of calcification is seen in the wall of the lesion. A tiny calcific concretion is also seen in the lower pole of the left kidney. Rest of the left kidney renal parenchyma is normal on enhancement and appear unremarkable. CT suggestive of Bosniak type 2 complex renal cyst.
Yes, sir.
Yeah. So now next what?
Sir, as per the CT report, it is a benign simple cyst of Bosniak class 2. So, sir, I would like to counsel the patient first about the diagnosis and further management. Sir, as this is a benign condition and the mass is less than 4, that cyst is less than 4 centimeter, I would like to counsel the patient about the management, that is conservative management at present, sir.
Boy, fish management?
Sir, conservative management at present, sir.
Conservative.
Yes, sir.
Patient had bleeding 1 year back.
Which type of cyst it is?
Sir, it is
Tushar.
type 2. simple cyst, sir, benign cyst.
How
Tushar,
come it
hold
is
on, hold
simple
on.
cyst?
Tushar, do you agree with this CT report? Because what you read and what they have given are different.
Yes,
So
sir.
why are you basing your decision based on what the radiologist tells you? Now is because what you feel and what the radiologists say are different. You need to confirm this before you proceed with treatment.
Yes, sir.
So how will you do that?
Sir, as the report is showing, it is a simple cyst, but I have seen as per the
Dekho, Tushar,
yes, sir.
what is mean by simple cyst? Don't
Uh,
go with that report. What is mean by simple cyst?
Sir, it is a containing fluid,
Containing clear fluid
clear fluid,
without
yes.
any internal septi,
Internal septation
calcification,
or non-enhancement.
any solid mass inside,
Yes,
and
sir.
posterior acoustic shadowing.
Yes, sir.
Correct.
Yes, sir.
So इसमें calcification है, enhancement है,
Yes,
hematuria
sir.
है.
Yes, sir.
So अगर simple भी है तो simple cyst का complication है. Correct.
Yes, sir. Yes,
जब
sir.
भी कोई भी cyst में hematuria, stone formation, infection, rupture ये चीज होती है तो that is indication for treatment. Not
Yes,
not for the such type of patient should not be for the conservative treatment. So here
Yes.
there is hematuria. Consider that it is a simple cyst
Yes, sir.
for some time.
Yes, sir.
Still conservative treatment cannot be defended.
Yes, sir.
Okay. So and against that simple cyst there is a calcification. There is a contrast enhancement at the capsular level or ring like calcification all around the cyst.
Yes, sir.
And where there is hilar near to the hilum and hematuria.
Yes, sir.
So are you happy that that cyst is simple cyst? It is given on the CT scan.
No, sir. Actually, CT, sir, it is a Bosniak class 2 cyst, so it might be a benign cyst that is having calcification and some minimal enhancement. Sir. It is not simple cyst. It is a mostly type of
So
complex cyst.
now you come from class 1 to class 2F.
Yes, sir.
Okay. 2F or only 2?
Yes, sir.
2F or only 2?
Sir, only 2, sir. Because it
So what is that 2F?
sir, 2F is a
Which needs F means follow up.
yes, sir. F means follow. Yes, sir.
Which needs follow up. Periodic
Yes.
regular follow up.
Yes, sir.
Correct.
Yes, sir.
So in this patient, you want to do periodic regular follow up as per you the treatment is conservative. So what
Yes,
is
sir.
conservative? What conservative treatment you want to give in this patient?
Sir, if the patient is having intermittent pain, so analgesic, and then patient is also having pus cells in urine, so course of antibiotic, and then sir follow up with USG report, sir, after 6 months.
Tushar, how do you explain pyuria related to this cyst?
Sir, might be it is secondary urinary tract infection.
How will that happen? Unless the cyst is blocking some part of PCS,
Yes,
how
sir.
can it cause infection?
Might be sir, there is a hemorrhage in the cyst that is leading to the secondary infection of the cyst.
So what that cyst is called as
Sir, hemorrhagic cyst,
hyperdensis.
hypertension. Yes.
So is there is hemorrhage inside the cyst in this film?
Sir, it is looking homogeneous.
So it will look exactly white on the non-contrast CT scan.
Yes, sir.
Okay, that is called as hypertension. तो ऐसा दिख रहा है क्या यहाँ पे?
No, sir, not exactly. It is looking not
जो
hypertension.
जो भी बोल रहे हो ना सोच के बोलो ना.
Yes, sir. Sir, it is not looking hypertense. I'm playing cities.
So finally, what you want to do, and what is your diagnosis, and how will you confirm your diagnosis?
Yes, sir.
Beta, is it a typical simple cyst?
Yes, sir.
Typical simple cyst.
No, sir, it is not typical simple cyst, sir. It is a, sir, complex type of cyst, sir.
And it has got a complication.
Yes, sir.
So do you think that by any method you are going to stop the bleeding?
Sir, yes, sir. If
How will you stop the bleeding?
देखो तुषार, सेम पेशेंट तुम्हारे ओपीडी में आया है, पेशेंट को हेमाचूरिया है और पेशेंट को सीटी स्कैन में सिस्ट है, तो तुम या तुम्हारे सर क्या प्लानिंग करेंगे?
सर,
ठीक है, another way, how will you treat his hematuria? Because he had intermittent hematuria already, one episode 1 year back, now 1 month से hematuria चल रहा है.
yes, sir.
Now 1 month continuously he has got.
Yes, sir. Then, sir,
How you are going to stop it?
yes, sir. Sir, if it is causing hematuria, then we have to do cyst excision, sir, enucleation of the cyst. Hello.
My question is why you don't want to do any surgery?
Yes, sir. Enucleation of cyst, sir.
Huh?
Sir, I will like to plan for the enucleation of cyst, sir.
And suppose what are the chances of this cyst having a malignancy?
Sir, there are very less chances, sir, less than 5% chances, sir.
5% chances. So
Tushar,
you do
it
enucleation.
Tushar, it is 2F.
Yes, sir,
As
less
per
than
you, it is
5%.
2F. So what is the incidence of malignancy in 2F?
Sir, it is less than 5%, sir.
Sure.
Yes, sir.
Abhishek,
Sir, I think around 30 to 40%, sir.
because type 3, type 4 definitely needs direct surgery, and the 2F definitely, whatever I remember, it should be more than 50, at least 15-20%. Okay, so 5% तो पक्का नहीं. So what I am remembering, it is 15 to 20%.
I think 5%
may
is
be-
for Bosniak 2 and 2F
Yeah.
is around 20-25%.
जी sir, जी sir.
Yes.
Now the important thing is if you are going to conserve, then you can say that 5% is a less small amount, and I will like to conserve. But in this case, if you are going inside and doing the surgery, why you want to do a conservative surgery? Even if there was 5% or 20%, if it is a malignancy, you are doing inadequate treatment. And already you are going inside, you are touching the kidney, you are doing all big exercise. Then why
Yes,
you want to do only enucleation?
Sir, because this cyst is having well circumcised margins, so
Suppose if you say, I want to do in this case partial nephrectomy, are you going to do more harm and you are not justified? There are two things.
no, sir.
Are you going to do more harm to this patient? You are going to do all the same steps of the partial nephrectomy. Only thing is you are going to do enucleation, and in
Yes,
that
sir.
you are going to remove very less amount of part of
renal-
the
Yes, sir. renal tissue.
cortex. And
Yes,
here you are going to remove more, little more. Still,
Yes, sir. Yes, sir.
the amount of kidney which you are going to leave behind is going to be a good.
Yes, sir.
Right or wrong?
Yes, sir. Yes.
Then there's a partial nephrectomy. I will like to do a partial nephrectomy.
Yes, sir.
Dr. Gite, what is your view?
Sir, considering the complicated cyst, it is definitely a complex cyst. It needs surgical treatment. So while doing the surgical treatment, it is better to do a partial nephrectomy in spite of enucleation.
Yes, sir.
So
Okay.
if it is possible to do enucleation considering hilar tumor and complexity, and if there is no solid element inside, enucleation also can be defined.
Sir,
So there is
sir.
ample literature which says that you do not need a very wide margin for RCC.
yes,
Agreed.
sir.
So do not say enucleation, say excision of the tumor
Excision.
with small
Yes,
margin.
sir. Yes, sir.
Okay. You see,
That will be better.
Yes, sir.
you see,
That will
learn
be
to
better
use
answer, sir.
proper words in exam.
Yes, sir.
The moment
Yes.
you see enucleation, a lot of people will jump on you.
Yes, sir.
So
Correct.
excision with a small margin of normal tissue. So then let the examiner go towards ki kitna margin lena chahiye and read that part.
Yes, sir.
So there is also literature that margin as small as few cell layer thick margin is also enough. So
Enough. Yes.
that is an old concept where you needed 4, 5 or 1 centimeter margin, 4, 5 millimeter or 1 centimeter margin.
Yes, sir. 2 millimeters. Yes.
2 millimeter is more than enough. So
Yes.
let's direct the examiner towards a field which we know better rather
Yes.
than going into enucleation, which is difficult to defend.
Yes, sir.
Correct.
Fine. So far as what we did, and just tell us the final thing.
This is the cystoscopy we have done to check for the lateralization of hematuria.
See, it was this exercise we have done
Yes, sir.
basically because just to say, because if CT scan, we had done 3 CT scans in 3 years, and none of the CT scans said that there is a definite mass. So we said, let us confirm with lateralization, whether it is coming from the right, left, or we should not miss anything in the bladder or in the prostate. So we have done first the cystoscopy, and we found out bleeding coming from the left ureteric orifice. So we confirmed that it is definitely from the left hand side, and then we went ahead and did a partial nephrectomy. As you can see here,
This is the left here.
see the blood is coming.
Yes, sir.
Can you
The
see?
blood is clean. Yes, sir.
Yeah.
Jet of blood is seen, sir.
I don't know whether we have done the right thing, Dr. Gite, Dr. Maheshwari.
Sir, cystoscopy is definitely justified, and I would have done cystoscopy definitely.
So in exam also they can always say that first of all,
Absolutely.
I like to,
Yes, sir.
You see, any patient with hematuria, contrast CT and cystoscopy both are important for completion of investigations.
Correct.
Yes, sir. Yes, sir.
fine. So just final, this is a kidney.
Patient was taken for partial nephrectomy, robotic assisted. This is the sample we retrieved.
Yes, sir.
On the final histopathology report, it turns out to be a clear cell renal cell carcinoma. Stage is T1B, NX, MX. Margin are uninvolved. There is no sign of tumor necrosis, no sarcomatoid or rheumatoid lesion identified, no lymphovascular invasions.
Fine. So I think we have done all these cases. So can we go ahead with the second case?
Yes.
Yes, sir.
Huh? Okay. So who is answering now?
Thank you, sir.
Dr. Shrikant.
Dr. Shrikant? He is there?
Yes, sir. I am here, sir.
Okay. Fine.
The second case, presenting a case of history of 63-year lady, resident of Madhya Pradesh, housewife, presented with the chief complaint of on and off pain in right flank since 4 months, burning during urination since 5 days.
Click. Come on. Click history. Very quick. We want to go ahead.
I would like to ask, like, what is the nature of pain? What are the aggravating and relieving factors? Is there any history of fever? Is there any history of urolithiasis before? Is there any decrease in urine output? Is there any history of hematuria?
Okay, Bharat,
Yeah.
give him the full history. Let him see what are the things he has missed.
According to the patient, she was apparently asymptomatic 4-month back when she developed pain in right flank region, sudden in onset, progressive, colicky in nature, non-radiating, associated with fever with chills, nausea, and burning during urination. The episode was aggravated during passing of urine and was relieved on medication. Patient has similar episodes since last 5 days, but with increasing severity, with fever with chills, frequency, and burning during urination. In the negative history, no history of trauma, no history of any urethral instrumentation or surgery in past, no bleeding disorder, anticoagulant therapy or blood transfusion, no history of lithuria or hematuria, no facial puffiness, pedal edema or breathlessness, no history of recent sore throat or skin infections, no history of jaundice, headache or backache. Past history, patient is a known case of hypertension, hypothyroidism and diabetes mellitus and presently on medications. There is history of modified radical mastectomy with radiotherapy in 2011. No documentation is available. No history of ischemic heart disease. Personal history, patient is mixed by diet, no allergy to any food or drug. Sleep is normal and undisturbed. Bladder bowel habits are normal and adequate. No addiction to any form of tobacco or alcohol intake. Family history is nothing contributory.
Fine. So now what is your differential diagnosis and what you will like to see in the clinical examination?
One differential diagnosis would be calculus disease, sir.
Okay.
On examination, I would like to see for any flank tenderness, any suprapubic tenderness.
So any other diagnosis you are entertaining except calculus disease? Only one diagnosis? Right loin pain and dysuria. 65-year-old female, diabetes.
Hypertension,
Sir, pyelonephritis, sir. She's having fever with chills since last 5 days.
Hmm.
And she's having dysuria also. She's a known diabetic.
So you are expecting which type of pyelonephritis?
Sir, actually patient has symptoms in the last 4 months, but like since last 5 days, she's having severe symptoms, sir.
Hmm.
So it can be acute pyelonephritis, sir.
Okay. Any other diagnosis?
Can be infected cyst?
Sir?
Can it be infected polycystic kidney?
Yes, sir, it can be.
At least 3-4 diagnoses there should be in your mind. Renal papillary necrosis, acute pyelonephritis, मेटोस्टेनोसिस, उसके बाद में रिकरेंट यूटीआई, उसके बाद में स्टोन डिसीज, उसके बाद में प्रोबेबल यूरेट्रिक स्ट्रक्चर एंड ट्यूबरकुलोसिस, कुछ भी रह सकता है ना. एक स्टोन पकड़ के काहे को बैठे, क्योंकि अभी आज अब तक तो एक दो ही पॉइंट पता है अपने को. एक तो पेशेंट को पेन है, रिसेंटली फीवर विद चिल्स है और डिस्यूरिया है, तो प्रोबेबली इट इज गोइंग टुवर्ड्स इन्फेक्टिव इटियोलॉजी. ठीक है. सो इन्फेक्टिव इटियोलॉजी का कुछ भी रह सकता है, एसोसिएटेड विद डायबिटीज है. ठीक है. हाउ विल यू गो अहेड?
First, I would like to go ahead with complete blood count.
एग्जामिनेशन नहीं करोगे?
On
पेशेंट
examination
का एग्जामिनेशन नहीं करना है?
करना है sir.
फिर
Sir, like on examination, like I would look for loin tenderness and there is a suprapubic tenderness, sir.
ओके. बोलो पारस बोलो.
General examination is grossly normal. On a per abdomen examination, there is no renal angle fullness noted on inspection. There is renal angle tenderness present on right side. Rest other is normal.
बोलो.
Next, bold boy. So now what do you want to do?
Sir, I would like to investigate the patient, sir.
Okay, so what are the investigations you like to do?
Sir, I would like to get a complete blood picture, urine routine and microscopy along with urine culture, and serum creatinine levels and serum electrolytes, sir. And would like to get a ultrasound abdomen, sir.
बोलो पारस बोलो.
On urine routine microscopy, pH is 6.5, sugar, protein are absent, RBC is 1 to 2 per high power feed, WBCs are 7 to 8 per high power feed. On culture sensitivity, there is a growth of E. coli with 1 lakh colony forming unit per ml, sensitive to fluoroquinolones, cephalosporin, and nitrofurantoin. Urine cytology is negative for malignant or atypical cell. On blood reports, they are grossly normal with creatinine of 0.82.
Show the sonography also, no? Please comment fast, whatever you are seeing.
The last film, like maybe slightly hydronephrotic kidney, sir.
ओके पारस रिपोर्ट बोल दो.
The impression is duplex moiety in the left kidney with dilated lower pole calyx with a query of Puget obstruction. Left kidney is normal, PVR is 20.
So बोलो what next?
Sir, I would like to confirm the diagnosis with CT urogram, sir.
This is the CT
So you
film.
want to start the treatment?
Yes, sir. Like I would like to start culture sensitive antibiotics, sir. Like initially empirical antibiotics followed by culture sensitive antibiotics, sir.
Okay.
Then like once fever is settled, I would like to get a CT, sir.
Okay. So this is the CT.
Yes, sir.
चलो पॉसिबल है तो रीड करो नहीं तो बोल देते.
Sir, grossly hydronephrotic upper pole, sir. and like surrounded by minimal parenchyma in the upper pole and hydronephrotic lower calyx also, sir, on the right side with the grossly dilated pelvis.
So, what is your diagnosis after CT? After seeing the CT?
See in CT, can you see on the right hand side there are double moiety, correct? But the lower
Yes, sir.
moiety is not connected. Means
Not
you cannot
connected to-
see it, sir.
Yes, sir, it's not connected to the system, sir.
So that is number one.
Yes,
Number two is the lower moiety, but still it is going right up to the upper calyx, upper pole.
Yes, sir.
As you said, no, earlier you said it is a upper polar, but actually it is a lower polar. As you can see on the left hand side, the lowermost. Right?
Okay, sir.
So it is a very complex type of double moiety.
Okay, sir.
Fine. So now what you like to do in this?
Sir, I could see very much thinned out parenchyma, sir.
So now what you want to do? You want to do any investigation or you want to do any surgery?
Sir, I would like to see the functioning status of the right kidney, sir, mainly.
Very good. So what you want to do?
Sir, I would like to get a DTPA done, sir.
Okay, bye. Paras, show him DTPA scan.
Yes. The CT reports were just a
Actually,
CT
can do
report.
that.
Yeah, on impression, there is a duplex collecting system in the right kidney. Superior and mid calyx show normal caliber and drain into a single ureter, which shows a normal opening with the urinary bladder. The superior moiety is non-obstructed and overlying parenchyma shows good thickness and prompt nephric excretion. The lower moiety is obstructed with significantly dilated calyx. The overlying cortex is thin, showing dilated nephric excretion. Delayed nephric excretion. This moiety continues with the dilated pelvis, showing tight PUJ. The draining ureter to this lower moiety is not identified.
Fine. Show him the DTPA scan.
This is the DTPA renogram.
Just tell him if he cannot see, just read it out.
The split function, the left kidney is 67% functional with right kidney of 32.9. Being specific, the upper moiety is 26% functional and the lower moiety is 6% functional. Not mentioned here. It is another slide. And the GFR per ml per minute is 59.9 for the left kidney and 29 for the right kidney. Time for
Fine.
maximum excretion is 5.135 for left and right is 11.2.
Fine. So now next, what you want to do? You want to do conservative treatment or you want to do some surgery?
Sir, I would like to first treat the present infection, sir.
Okay, the infection is under control. We have given antibiotic as per the concern and sensitivity report, and
Yes, sir.
patient is improved. Now what you want to do?
Sir, split renal function of the right lower pole is very less, sir. And so I would counsel
Dekho, Sri,
sir.
any duplex system, there are 5-6 questions you have to ask yourself. One
sir.
is it a complete duplex? Is it incomplete duplex?
Yes, sir.
One. Then the differential, then if it is joining, if it is incomplete, it is joining at which place?
Which level? Okay, sir.
Okay. Third, any of the moiety, is it obstructed?
Yes, sir.
Fourth, any of the moiety, is it refluxing?
Okay, sir.
Fifth, then is any moiety is having internal debris inside an infection, pain, fever, tenderness.
Yes, sir.
Okay. Then differential function of each moiety.
Yes.
And then CT scan oblique MRI. MRI will be the best for identifying such type of lesions inside the body, better than the CT scan, because obstructive system urine will act as a contrast.
Okay, sir.
And as per the function, level of bifurcation, completeness and incompleteness, and amount of function, we have to plan for the upper track approach or lower track approach.
Yes, sir.
So if it is associated, if it is a complete duplex, and if both the upper both the moiety is functioning, and if it is associated with the viewer, it is common C3 implantation. Suppose both the moiety is functioning, but there is no viewer, and
Yes, sir.
one moiety is obstructed, then you have to de-obstruct that moiety by doing the upper track approach like ureteropylostomy at ureteropylostomy.
Okay, sir.
Okay, so obstructed system pelvis should be joined to the non-obstructed system ureter.
Okay,
Suppose both the system is non-obstructed and doesn't have any viewer, but one moiety, upper moiety is, for example, it is not functioning, or lower moiety is non-functioning. Then again upper track approach, and that particular moiety you have to do heminephrectomy, or that moiety should be removed.
Okay, sir.
So these are the permutation and combination in such type of patient. You should be ready with all these answers.
Okay, sir.
Fine. So in this case, what we like to do? Will you like to do any other more? Because do you think it is a very typical case? Because they are saying lower moiety, there is a duplex system with the lower moiety, correct?
Yes.
And at the same time, you in the CT scan, it is showing that it is going up to the upper pole.
Yes, sir.
Now you want to do any other investigation to become a visor, or you want to find out whether this moiety is really functioning, not functioning? You want to do anything?
Sir, like I would like to do a MCU, sir.
Okay, what else?
Sir.
Okay, MCU, there is no reflux.
There is no reflux in MCU.
And you have treated the infection by giving the culture specific antibiotic. And this is the DTP scan having a differential function of each moiety in front of you. So what is your planning?
Are you able to see the lower moiety?
I have already
ureter?
given all type of permutation combinations. You have to give just answer.
Yes, sir. I would like to do a pilogram, sir, and see like where the collecting systems are joining, sir. Like do a
Fine.
ureterogram and see.
Okay. By Paras, RGP दिखाओ.
Yes.
So you want to do RGP in same setting, or you want to do RGP different setting?
Sir, would like to do.
Dekho, the CT is clearly showing there is incomplete duplex. DTP
Yes,
is clearly showing one moiety is nearly gone.
Yes, sir.
Okay. So doing a RGP in different setting is good idea, or doing RGP in same
Same
setting
setting,
is good
sir.
idea?
The same setting is a good idea.
So plan the surgery and go for RGP, na? If you have any
Yes, sir.
doubt. In same
Yes, sir.
setting.
Yes, sir.
So now this patient outside only, she had undergone cystoscopy, RGP, no findings were there, and nephrostomy was done because they could not identify the lower moiety ureter or pelvis or whatever it is. So they did nephrostomy.
Yes, sir.
Nephrostomy. And nephrostomy was draining about 700-800 ml of urine. Now,
Yes, sir.
what we do? So we did, Paras, show them
Yeah.
RGP.
This is the nephrostogram we have done in the OT. And
This is the
the
nephrostogram.
RGP. This is the RGP.
And the right hand side is RGP. So can you see nephrostogram? And then
This
can
is
you
the
see it is overlapping the normal ureter, upper moiety ureter. Just show him the upper moiety calyx on the right hand side. Paras,
Yes, sir.
on the right
This-
hand side. Yeah, see that
Yes,
is the
yes.
that is the upper moiety.
Okay,
Okay,
sir. Okay,
and
sir.
all of other everything else is a lower moiety, as you can see in nephrostogram.
Yes,
This
sir.
this is a guide wire we have put in the upper moiety. This
Okay,
is
sir.
So now
This-
what? What is your plan? 800 cc of urine. It
So
is draining.
why someone has placed the nephrostomy? Because this patient had recently fever with chills and ultrasound suggested of internal debris in the upper moiety or lower moiety. I am not remembering, but one moiety there is a debris.
Yes, sir.
yes.
Okay. So to drain that, probably someone has placed the nephrostomy in that particular moiety. Again, you have a chance now. So reassess the function. That nephrostomy is draining 700 ml.
Yes, sir.
Okay. So is that urine? Is that only water?
Yes, sir. Like we can.
Is it matching with the DTP report of DTP report, which is showing the differential function of both the moiety?
It is not matching, sir. Like to see for urine osmolality.
So specific gravity and urine osmolality.
Yes, sir.
Fine. So now what is your plan? What you will do in this patient?
So first of all, tell me which moiety is completely gone, upper moiety or lower moiety?
Upper moiety is poorly functioning, sir.
This is upper moiety, beta.
Yes, sir. That's the upper moiety.
That is, even the CT scan is showing it is functioning well.
Yes, sir.
In the IDP, you can see it is functioning well and the ureter is well opacified. Then
No,
So the
मेरा
lower
question,
moiety is definitely-
why I asked this question is because which moiety you are going to remove if you are planning for any surgery. So lower or upper or both.
Lower, sir.
So amount of lower moiety compared to amount of upper moiety. So which lower moiety is probably 2 calyx and upper moiety is single calyx. So how much kidney is remaining behind?
Only around 1/3.
So that's why while giving the answers, you should be in exam also. You should write down in front of your small sheet which moiety is which, how many functioning, अपर मोइटी का कितना फंक्शन है, लोअर मोइटी का कितना फंक्शन है, वो बताने वाला बता के भूल जाता है, अपन भी बाद में भूल जाते।
ओके।
तो ये एग्जाम में ध्यान रखना कि जो भी बता रहे एक छोटे चिट्ठी पे लिख देने का।
यस सर।
फिर तुमको कंपेयर एग्जाम में अगर तुमको ऐसा कुछ कंफ्यूजन हो गया तो वो चिट्ठी को देख के एग्जामिनर के सामने भी लिखा तो कुछ फर्क नहीं पड़ता। फॉर रिमेम्बरेंस इट इज नॉट बैड आइडिया।
ओके सर।
तो अभी इसमें सीटी स्कैन, डीटीपी स्कैन एंड नेफ्रोस्टोग्राम, ये सब चीजों को मैच करने के बाद में इसका क्या ट्रीटमेंट करेंगे बताओ। अगर नई कंफ्यूजन हो रहा तो फिर एक बार पूछो तीनों रिपोर्ट। बोलो।
Yes sir.
While guess, see, either you are going to do, there are only two options, correct? Either you are
Yes, sir.
going to do partial nephrectomy,
Yes sir.
or you are going to do reconstructive surgery.
Yes.
You want to overcome obstruction, correct?
Yes sir.
So what you want to do?
तो मैं अगर तुम्हारे जगह पे होऊंगा तो मैं पूछता हूँ भाई मुझे तीनों रिपोर्ट फिर एक बार बता दो। आई वांट टू रीऑर्गेनाइज माय सेल्फ।
भाई सीटी स्कैन सबसे पहले बता दें।
यस सर। CT impression shows the duplex collecting system.
लास्ट फिल्म दिखा दे उसको,
Okay.
लास्ट फिल्म, उसके पहले वाली फिल्म दिखा दे खाली। पारस वन बिफोर, थोड़ा मूवमेंट कर, हाँ। See the left hand side lowermost, okay? Okay, can you see the upper, left hand side upper?
Yes,
How
sir.
much is that? Even though it is a two calyx, just see lower three. Can you see the amount of
पारस,
Yes, sir.
Yes.
उसको तीनों रिपोर्ट बोलो एक बार, सीटी
Yes.
स्कैन का,
Okay.
नेफ्रोस्टोग्राम का और डीटीपीए का, then he will probably reorganize himself.
The CT report suggestive of a duplex collecting system is seen in the right kidney, with superior and mid calyx show a normal caliber and drain in a single ureter, which shows a normal opening into the urinary bladder. The superior moiety is non-obstructed and overlying parenchyma shows good thickness and prompt nephric excretion. The lower moiety is obstructed with significantly dilated calyx. The overlying cortex is thinned, showing delayed nephric excretion. This moiety continued with dilated pelvis, showing a tight PUJ obstruction. The draining ureter to this lower moiety is not identified.
Okay, so
Yes, sir.
lower moiety is ballooned out with ballooned penis, pelvis, just attaching to the upper moiety ureter.
Yes, sir.
Correct. And upper moiety is draining without any obstruction. So here, next question I want to ask to Paras is, what is the function of lower moiety?
Yeah. The DTPA renogram shows upper moiety is right side is unremarkable with adequate cortical function, non-obstructed. The differential function of right kidney is 32%. The lower with the upper moiety is 26 and the lower moiety is only 6%.
So again, upper moiety is functioning. Whatever the function is there, upper moiety, lower moiety already gone. So
Yes,
what is the finding of nephrostogram?
On the left hand side, there's enough.
First question is which moiety nephrostomy is placed?
The nephrostomy is placed in the lower moiety.
Okay. So what is the finding of nephrostogram?
can you see it is a totally ballooned out pelvis and calyx and everything,
Yes, sir. Grossly hydronephrotic.
grossly hydronephrotic. So now what you want to do?
So it's very simple, na? Everything is in all the reports. So in spite of nephrostomy draining 700 ml, you
Yes, sir.
just go for that specific gravity and osmolarity, confirm it is not urine, it is only water, and then remove that moiety.
Yes, sir.
Fine. Understood? So that is
Yes, sir.
what we have done. The other option was to do pyloureterostomy, but in this case, if you do it, then there are chances that it may also cause lots of again stricture, infection, that upper hydronephrotic kidney part will not subside. It can cause damage to the normal kidney also. So considering all these things, we decided to do partial nephrectomy. Okay?
Okay. Okay, sir.
Yeah. So just show them
Yeah.
the pelvis.
Initially, we have stented the upper moiety. This is the normal ureter with a stent. This is a renal vein. This is the dilated lower moiety. This is the probable site of PUJ obstruction of the lower moiety.
Okay.
Above that, there is a dilated pelvis. Okay. So we have done the partial nephrectomy. In short only, I will tell you that 4 days later, we have removed the drain. Everything was okay. And after discharge, 2 days later, patient developed fever and vomiting. We wanted to admit she had a COVID. She got admitted in a COVID ward. She has got severe diarrhea, distension. CT scan was done.
Collection.
There was a small collection, 50 cc collection. Just read it out.
Yeah. In the post-operative status of right robotic assisted partial nephrectomy in a duplex moiety, there is a 6.4 into 3.4 into 8 centimeter collection with air specs in the surgical bed on the anterior to the residual segment of the right kidney. It is approximately 50 to 60 ml, likely infected collection or abscess. There is no demonstrable leak of contrast from the residual segment of the right kidney. The DJ stent is noted in the right ureter.
Okay. So we decided to aspirate it and just show the report.
Yeah. The report is suggestive of E. coli with sensitivity to fluoroquinones and cephalosporin. And the stool test is positive of Colistridium difficile, suggestive of pseudomembranous colitis or megacolon.
Okay. So now she has got distension. Otherwise, she is well settled. And we have to now treat her megacolon. We have aspirated. So that 50 cc is gone. Okay. Now we'll not go ahead. This is just for information. What are the complications can take place? We'll go with the third case.
Yeah.
Okay.
Thank you.
Yeah. Who is answering third case?
Dr. Abhishek and Dr. Amit.
Okay, fine. Go ahead.
The third case.
Yeah.
A 46-year-old gentleman laborer presented with the chief complaint of right flank pain on and off since 1 year.
We cannot see your screen. Huh?
Okay.
CT scan दिख रहा है पारस.
1 minute. Chief complaint, 46-year-old gentleman laborer presented with the chief complaint of right flank pain on and off since 1 year.
Yeah, Abhishek, quick.
Yes, sir. Sir, so 46-year-old gentleman, right flank pain. I'd like to know the onset, duration, progress of the pain, sir. Was it insidious or associated with any factors? Is it what the nature of the pain, sir? What kind of pain is it? Does it have any aggravating or relieving factors? Does it radiate to any side, sir? What is the relation with medication, sir? Is it relieved on medication? What did the patient? What has the patient? Are there any previous history of similar pain episodes? And if there is, then what did the patient do for such pain episodes? And yes, sir. And any associated history of any previous stone disease or sir passage of stones, sir, lithuria, or sir any history of fever associated with the pain, sir? Any history of fever or hematuria associated with the pain? Any history of passage of stones? Any history of lower urinary tract symptoms associated with the pain, sir? And yes, sir.
Okay, Paras, just give him the full history. Let him see what he has missed out.
History of there is history of on and off pain in the right flank since 1 year, insidious and onset, dull aching, non-radiating, no specific aggravating factor, and was relieved on taking oral medication. Patient also have a complaint of fever with chills since 7 days. No definite pattern, no documentation prior to admission, with burning during urination, and was relieved on medication. There is no history of nausea and vomiting, hematuria or lithuria. There is no history of lower urinary tract symptoms, no trauma or bleeding disorder, not associated with nausea and vomiting, no alteration in bowel habits, no facial puffiness, lower limb edema or respiratory distress.
Fine. So next, Amit, what do you want to do?
Sir, I wanted to do a general examination and
Any other history?
sir, any history of any surgical history or
That is all
history of
done.
diabetes, hypertension, or pulmonary tuberculosis.
So personal. Paras, give him the full.
Past history, patient is known case of hypertension on medication. There is no history of diabetes, tuberculosis or ischemic heart disease. There is history of an endoscopic procedure for right renal or ureteric calculus 3 years back. No documentation is available. personal history, no significant family, personal and family history, no significant family history, no addiction, no alternation in sleep habits, no altered bowel bladder habits, or no history of drug allergy.
Okay. So now what you want to do?
I would like to examine the patient, and then
So
according
what are
to
the
that,
important things you are expecting?
renal angle, fullness, tenderness, or any lump is palpable or not, and suprapubic fullness or tenderness or bladder is palpable or not, or in DRE, status of the is there any constipation or status of the prostate.
So why bladder will be palpable in this patient? So what are the chances of palpable bladder and why? This patient had some endoscopic surgery 3 years back probably. And what sir's question is what you are expecting in this patient. So if you are what you are expecting in this patient. So you have to depend it. That endoscopic procedure may be via you, no?
Yes.
So patient may have stricture.
Stricture. Yes.
So there may be palpable bladder. इतना क्यों सोचना है? फट बोल के दिमाग में आ जाना चाहिए. हमने जो बोला है उसको डिपेंड करना पड़ेगा. नहीं तो बोलना नहीं फिर.
Yes.
ठीक है आगे.
General examination is grossly normal, and systemic examination is also normal. No reason.
Okay. So overall
now
only
what you want to do?
1 or 2 complaints. That is one positive history, endoscopic surgery 3 years back, and now right loin pain
And fever since 7 days.
and fever since 7 days. Okay.
So what do you want to do now?
Sir, I'd want to investigate the patients. I would do some routine investigations, including complete blood counts, urine routine microscopy, urine culture sensitivity, and an ultrasound of the abdomen, sir. Yes, sir.
And serum
Only
creatinine.
abdomen?
Serum,
Abdomen and pelvis.
Abdomen, pelvis, yes, sir. Abdomen and pelvis.
That will say properly.
Sorry, sir.
Fine. Paras, show them.
On urine routine microscopy, the WBC are 10 to 20 per high power field, the RBC are 1 to 2 per high power field, epithelial cell are 3 to 5 per high power field. Culture sensitivity show no growth. On laboratory investigation, the WBC total leukocyte count is raised. It is about 17,900 with neutrophil about 82%. Creatinine is 2.1, rest are normal.
And sonography?
Yeah. The film is not available. The report is suggestive of a right kidney pelvic calyceal system, 25 mm calculus at the pelvis with mild hydronephrosis, 4.8 mm calculus in the upper pole, few calculus largest 10 mm in the upper portion of the right ureter adjacent to the DJ stent in situ. On the left kidney, pelvic calyceal system is normal, mild hydronephrosis with few calculus of largest 5 mm in the left lower pole with 5 mm calculus in the proximal ureter. Prostate is 30 gram, bladder is collapsed.
Fine. Abhishek, what you want to do now? So what is the inference? What are the positive findings in sonography?
Sir, there appears to be multiple calculus in the pelvis and the ureter on the right side, sir. And there is also right DJ in situ, sir. So this appears to be a case of retained DJ stent, sir. Forgotten DJ stent, actually, sir.
With left side upper ureter and renal stone.
Yeah.
Yes, sir.
So you have forgotten that.
Yes, sir.
So now what you want to do? Is there any history, Gite sir, of doing DJ stenting in the recent past, or this is the old one?
Old one, sir.
Old DJ, na?
Yeah,
Sir,
it is written forgotten disease.
Sir, he gives history of right calculus, some right calculus disease operated 3 years back, but rest of the details are not available, sir.
Only one surgery he had 3 years back. No
Yes, sir.
other.
Fine. So now what you want to do, Abhishek? Remove the digestion.
Sir, I do a PCN, sir, first, because creat is 2.1.
You don't want to do any other investigation?
I would like to do non-contrast CT scan.
Non-contrast CT scan, sorry, sir, yes.
And what else? So a non-contrast will
Stabilize
show
the
you-
patient.
No, non-contrast will not show you the function.
Sir, but it will show
Sir,
the roadmap.
Anatomical roadmap and, sir, the probable, sir.
Yeah. I agree. What I'm asking you is, if it's not going to show you the function, so for that, what you can do?
Sir, first I would want to stabilize the creatinine, sir, then go ahead with the DTPS scan for function, sir.
Okay, fine. So show them
So-
CT scan.
So how will you stabilize the creatinine?
Sir, I would evaluate the patient, sir, serum for AKI, sir, serum electrolytes I would want to see, sir, and serum, yes, sir, take a nephrologist opinion, sir, and start of the patient with, yes, sir, manage the electrolyte imbalances and, sir, provide a drainage system for the kidney, sir.
So all these reports are normal. Serum creatinine 2.2.
Yes, sir.
Nephrology says continue antibiotic and continue your line of management.
I will
Yes, sir.
like to divert the urine of the right side.
Yes,
So
sir.
why you divert the
In form
urine?
of the
Have you
because
confirmed that system is obstructed? Have you confirmed that is that raised creatinine is due to obstructed system? There is already stent inside. Have you confirmed that there is any debris and internal lipase inside that kidney? Then how you have planned the placement of the patient?
Yes,
So
sir.
think before answering, boss. So first ask the CT scan, just NCCT, you see the film first.
yes.
Or if you don't want to do NCCT, at least ask to sonologist, is there any internal leakage inside? Is this any findings suggestive of pyonephrosis? So if that system is decompressed inside with DJ in situ, so what you will gain by placing the PCM?
Show them the CT scan, Parag.
पंकज सर बीच बीच में ओपिनियन देते रहे ना.
बिल्कुल बिल्कुल, I'm
Okay.
there, don't worry.
Today's all the cases are very important for, Pankaj is the comments and his view.
होना चाहिए, इंतजाम होना चाहिए.
Yeah. So Abhishek.
Sir.
What are your findings?
Sir, the obvious finding of the digestant on the right side can be seen,
होना
sir.
चाहिए, इंतजाम होना चाहिए.
And sir, there appears to be some thinning of the parenchyma on the right side. And the ureter also appears to be dilated, sir.
And
left side lower polar stone with upper ureteric stone with
Yes,
mild
sir.
hydronephrosis, and right side moderate to gross hydronephrosis with thinning of parenchyma.
And what is this?
एक बार पक्का देखो.
Degescent in the ureter and in the bladder.
But see, what is that?
Broken
The
degescent.
ureter. Oh, yeah, what are these? Is a normal degescent or something is there along with it?
So there's a lot of encrustations on the digestion, sir.
Okay.
Will you call it
Parason-
incrustations or
para-
stones?
Yes, sir.
Sir,
Maheshwari,
they
sir,
are,
ask some-
yes, sir. Sir, they appear to be along the course of the digestion. So, sir, I think encrustations.
See-
Encrustations of the stent are usually all around, na?
Yes, sir.
Now comment.
So, is
There's a multiple stone in the upper ureter, sir.
Yeah. See, unless and until you have seen good number of CT scan, X-rays, you will not be able to diagnose all these things. Fine. Now next what? Yeah, read the report.
The CT report is suggestive of in the right kidney, mild pelvic calyceal fullness is noted. The AP diameter of the renal pelvis is 14.5 mm. Few hyperdense average attenuation of 686 Hounsfield unit calculi are noted in the upper pole of the right kidney with largest of 5 into 3 mm. DJ stent is seen in situ with proximal end in the proximal ureter and the distal end is present in the urinary bladder. A hyperdense calculus of 14 into 27.2 into 12.6 mm and of 1244 Hounsfield unit is noted in the renal pelvis of the right kidney. A few 4 hyperdense calculi with the largest of 11.2 into 7.5 mm and of average attenuation of 948 Hounsfield are noted in the mid portion of the right ureter adjacent to the upper end of the DJ stent at the level of L3 vertebral body and extending up to the body of the L4 vertebra. The left kidney, multiple hyperdense calculi are noted scattered throughout the renal parenchyma with the largest measuring 0.76 into 0.58 centimeter of average attenuation 1122 Hounsfield noted in the lower pole of the left kidney. Mild hydronephrosis with mild proximal hydroureter is noted. A hyperdense calculi of 0.45 into 0.5 centimeter with average attenuation of 860 Hounsfield is noted in the proximal portion of the left ureter at L2 vertebral body level. Rest organ are normal.
Fine. So Abhishek, now what you want to do?
Sir, I'd want to
Is
evaluate
creatinine
the
very high in this patient?
2.1 it is, sir.
2.1.
So can you bring it down or you want to go ahead with this creatinine and finish off the job?
So we want to bring it down.
Bring
Sir.
it down, sir.
You think how much it will come down?
Sir,
Sir,
at
if
least
we divert the urine, then it will come down to the normal, sir.
Why has this
Diverse
creatinine
one.
gone up?
Because there is a infected system in the right side, sir.
So why should that cause risk creatinine?
And left side also.
That's better. So probably
Obstructing
this
the-
creatinine, acute rise of creatinine is because of obstructive
Bilateral.
uropathy on the left side.
yes.
Yes.
Right side was already obstructed for a long time. Now the left has also got obstructed, so his creatinine has gone up.
Yes, sir.
So when you say divert, then what is your plan?
Sir, by putting left side degescent and right side PCN, sir.
Perfect. So the moment you put a left digest stent, you will expect this creatinine to come down. And right nephrostomy more from the point of view of control of infection and as access for further treatment.
Yes, sir.
Can you think of doing the left side definite treatment with the digest stenting with 2.1 creatinine, or you want to wait for creatinine to come down?
I wanted to creatine.
If
come
our
down.
answer is that you want to, try to bring it down and then give the best treatment.
Yes, sir.
Even though 2.1 is not very high creatinine, right? Still,
Yes,
you
sir.
will like to bring it down and give the best treatment. So, no, you should be prepared for the answer na, in exam.
Yes, sir.
This is 2.1. Suppose creatinine is 1.8.
And patient, sir, count is also high, sir. So patient is
Yeah.
in the
So you would
sepsis
like
with
to.
the test grades.
Correct. And
So,
you are not
Amit,
100% sure that it is
Amit,
only the
is,
right.
is it okay to reposit the right digest stent and place the stent on left side? Or you want to place PCN only?
Sir, I want to place PCN only because the stone burden in the right side is high. So in future, I will need the access in the right side from the antegrade. And in the left side, degestion is sufficient at present.
Okay.
Okay, sir. So now what was done? Paras,
For this, in the view of high creatinine and high total leukocyte count, patient was taken up for right digest stent change with left digest stenting, follow with a follow up of 2 weeks. With
so what was the, yeah, later on what done?
in the stage 2, right antegrade URSL with right PCNL with left URSL with bilateral digest stenting was done.
Fine. Okay. And what was done for these multiple stones? How they were tackled?
So they were tackled by placing 2 ureteric catheter, the proximal one proximal and one distal, and then the patient was turned to the prone position. These catheter was placed so that the stone may not get dislodged. RGP was done with showing evidence of dilated pelvic calyceal system with pelvic and the multiple ureteric calculi were seen. These are the ureteric catheter placed. This is the upper ureteric catheter and this is the lower ureteric catheter. This can be seen on the C-arm image also. These are mainly done to prevent the calculus from.
This is a jugaad. What they did, because of many times what happens, you plan out for a antegrade PCNL and URS, and then stone migrates down, in the ureter, and then again you have to make the patient, and you try ureteroscopy, and the stone goes up. So instead of that, what they did, they kept one ureteric catheter below the calculi and one across, and they finished the job so that the stone cannot, go down into the ureter.
Sir, in this case, can we, if we have facility, we can say ECRIS is the option.
RIRS?
ECIRS, endoscopic combined intrarenal surgery, sir. PCNL from above and URS from below.
Yes.
Agreed.
You can. Yes, you can do it. Definitely.
Rather, I would feel that should be the first treatment option you should talk about.
Correct.
Okay, sir.
So this is what it was done.
Sir, differential function, whether to evaluate or not, sir?
Once the
Yes, if it
obstruction is removed, you can do it. Na? Better to do it when there is no obstruction. Na?
Right.
Only the thing is, in this case, now, fiber optic is going to be a very difficult thing to do it from below. So you have to do rigid only. You know, with the rigid only you can push it back, but sometimes that also becomes little difficult. Dr. Maheshwari, what is your opinion?
Yes, I agree, sir. Means you would be able to use fiber optic or flexible only if you have access to holmium laser.
Yeah.
Otherwise, antegrade, a rigid ureteroscope or even nephroscope can easily reach up till the level of L4. And with the ureteric catheter that Dr. Gite had kept below the stones, it will always be possible to flush these stones up.
Right. So everything depends upon the situation and the availability of the instrument.
Equipment, yes.
Fine.
I think
Anything else?
excellent job done.
Yeah. Anything else? One is, as you said, the ureterinoscopy along with the PCNL or antegrade PCNL with what Dr. Gite has done. Anything else? Abhishek?
Sir, we have to tackle both the kidney in the same sitting, or we can state the procedure one kidney at
Oh, you
at
are surgeon. You tell me what you want to do. The patient has come to you, what you will do, what you are comfortable with.
Yes, sir. The left side we can offer URSL with ESWL for kidney stone.
Okay, chalo, accepted. Or you can, if you have got a facility, you can do RIRS.
RIRS,
fine.
yes, sir.
Yes, sir.
Then
Why didn't you consider ESWL for the ureteric stone?
Abhishek, answer.
Sir,
You people are doing in Jaslow.
Sir, because we are going in the for the right side, so we can have a look on the left side also. We have already stented the ureter.
You see, bilateral endoscopic procedure is not something which everybody would undertake very easily. Anyway, that could be one of the practical reasons. But with a stone which is less than around 900 Hounsfield unit in upper ureter, even ESWL would be a good option when the stone is less than 10 millimeter. So don't forget ESWL as an option.
Yes, sir.
See, ESWL का problem क्या है? Not many centers are having. So, like, you know, we always miss it out.
Yes, sir.
And
But exam it is important that they
that's what I'm
remain
saying.
aware about ESWL.
Exactly. That's what I'm saying, that we miss out on important thing because we are not doing it. So that option doesn't come in our mind. So that is
True,
why
sir.
we have to remember this. Fine. So anything, what about open surgery? Can you give that option, Abhishek?
can be done, sir. Option can be given to the patient, sir.
So what you will do in open?
Sir, open pyelolithotomy and open ureterolithotomy, sir. The right side, sir.
How many
Abhishek, you want to open the ureter at both place?
No, sir.
Sir, at one place.
Only at one place.
How much is the stone burden? Is it not possible to tackle with endoscopy?
Yes, sir. It is better tackled with endoscopy, sir.
So if you don't have any facilities of endoscopy, refer the patient.
Okay, sir.
Because if you tell in exam it is open surgery, then
So why I
open
asked them-
surgery has its own morbidity.
Yes, sir.
Yeah.
Okay.
Why I asked them, because in one of our meeting, in the Mumbai Society meeting, similar case had come and they had shown the open surgery. They had opened up the pelvis, removed the stone, and they had squeezed the ureter, and they have brought all the stones up into the kidney and removed. So this is what one of the institute had done. So
So
that's
again,
why I asked.
if the examiner insists, you can say that it is possible, but in today's time, probably it is not needed.
Yeah.
Okay.
I agree.
Will you treat it purely by flexible ureteroscopy? The right side.
Sir, flexible ureteroscopy, sir, sir,
not
a
possible.
rigid would be a more feasible option.
No,
on the
you
right.
also have a large renal stone burden and ureteric stone burden, so both can both be managed by flexible URS.
No, sir. No.
Abhishek, rigid ureteroscopy is made only for the lower ureter and
Yes, sir.
partially for mid ureter. This stones is in the upper ureter. So question, you understand the question of sir?
So
Is
only
there any
RIS
role
is,
of flexible URS in this patient?
so
RIS.
only flexible RIS is not possible. We
Why?
have to combine both options, RIS
Why?
and PCNL.
Why flexible RIS is not
The
possible?
flexible RIS, it will take a long time, sir. It is more than
Stone is
2
too,
centimeter.
sir.
Burden is more than
So the
limit
answers
of the
are two.
RIS.
One is that the stone burden is very high, and also the HU is very high.
Yes, sir.
So HU is, if I remember, around 1500 for
1200.
both the stones.
1200
Yes,
something.
1200. So because of large stone burden and large HU, flexible ureteroscopy may not be the option. With PCNL, it will be much more comfortable and much faster and much higher success rate of complete stone clearance.
Stone clearance. Yes, sir.
Fine.
I think
Anything
so.
else?
I think that's it.
Because now we will be doing OSCE. What about any, Gite sir, any report on about examination?
No sir, no. फिलहाल तो कोई मैसेज नहीं है किधर से भी, लेकिन कुछ है तो बताता हूँ.
Okay, so in between one of this Friday we do OSCE.
Yes, sir.
चलेगा जैसा भी आपको कंफर्टेबल रहेगा.
Okay.
स्टूडेंट्स
So
को
I'll
जो
let-
कंफर्टेबल है वो करेंगे, कोई इशू नहीं.
Yeah. So group पे डाल दो, Abhishek. Please
Yes,
ask
sir.
everyone and put it on a group, and we'll go
Yes,
ahead
sir.
accordingly. Because
Yes.
now the NCH exams are also going on. I think in another 5 to 7 days they will also be completing their theory exam, and then they have got a very short period of time. They will have only 15 days probably for their practical exam.
23, 24, 25 है सर एमसीएच का, एक्चुअली कर्नाटका का.
हाँ.
तो वही रेंज में कभी ना कभी अपने पास भी होगा.
चालू हो गया ना अपना महाराष्ट्र से.
हाँ, थियरी शुरू हो गया.
And I think practical is on 17th or 18th of August.
हाँ, 10-15 दिन के गैप से आ ही जाता है.
Yeah. So DM is already there on 16th or 17th. So we have got only 15 days left. So we want to utilize maximum, this 15 to 3 weeks. So let us know what, which way you want to go ahead, and we'll manage that way. Abhishek, your
Yes.
responsibility, because people are not, open on the group. They are not writing down everyone, their suggestion. So you ask them personally and put it on a group. Okay?
Okay, sir. Okay, sir.
Okay. Fine.
Excellent.
Good night. All of you are
Thank you,
doing
sir.
well.
Good night. Very
Good.
good.
Good night sir, good night.
Thank you, sir.
Good night.
Good night, sir.
Thank you,
Thank you,
sir.
sir.
Pankaj Bhai.
Good night,
Thank you, sir.
Gaurang
Good
Shah,
night.
sir. Good night, Gite, sir. Good night, Maheshwari, sir.
Good night.